Welcome to Med Studious. In this video, we are building the complete surface anatomy blueprint of the abdomen and lower extremity, the topographical guide for clinical examination that every doctor, nurse, physiotherapist, and medical student must master before they can examine a patient confidently. Surface anatomy is a discipline that bridges two worlds, the visible world of the skin's surface and the hidden world of deep structures beneath it. When you look at a patient's abdomen, you are not just seeing skin. You are reading a map of the organs below. When you examine a patient's leg, every muscle bulge, bony prominence, and skin crease is telling you something about the deep anatomy underneath. This video will systematically walk you through the clinically essential surface landmarks, from the midline structures of the abdomen and the surgical geometry of McBurney's point, through the pelvic boundary, down the thigh, across the knee, along the calf, and to the very base of the foot. Each landmark connects directly to a clinical examination skill. Let's begin.
Before we map individual landmarks, we need to understand why surface anatomy exists as a clinical discipline. From a diagnostic perspective, most anatomy is hidden. The heart, the liver, the femoral artery, the sciatic nerve, none of these are directly visible. Yet clinicians access information about all of them every day using nothing more than their hands, their eyes, a stethoscope, and their knowledge of what lies beneath the surface. This is why mastering the visible landmarks on the skin's surface is the absolute prerequisite for performing classic physical examinations. There are 5 examination modalities that rely entirely on surface anatomy knowledge. Palpation is the act of feeling for structures beneath the skin, pressing, probing, and identifying masses, tenderness, pulses, and organ margins. Auscultation is listening to internal sounds using a stethoscope placed over precisely known surface locations: heart sounds, bowel sounds, arterial bruits. Percussion is tapping the surface to assess the density of underlying tissue, resonant over air, dull over solid organs. Inspection is visual observation of form and contour, and function testing assesses biomechanics through movement. All 5 modalities depend on knowing exactly where you are on the body's surface map.
We begin our surface anatomy tour at the most visible and clinically important midline structure of the anterior abdomen, the linea alba. The linea alba, Latin for white line, is a fibrous band formed by the interlacing of the aponeuroses of the 3 lateral abdominal muscles, the external oblique, internal oblique, and transversus abdominis. It runs longitudinally in the perfect midline of the anterior abdominal wall, from the xiphoid process of the sternum superiorly to the pubic symphysis inferiorly, running in direct line with the rectus abdominis muscles flanking it on both sides. In muscular, lean individuals, the linea alba is visible as a slight midline depression between the 2 rectus columns. It is the primary surgical incision landmark for midline laparotomies because it is relatively avascular. Cutting through it minimizes bleeding. A critical clinical note: in obese patients, the linea alba may be completely invisible and may even appear distended or bulging. This is called a diastasis recti, when the rectus muscles separate, which is common after pregnancy. At the midpoint of the linea alba lies the umbilicus, the navel, a scar remnant from fetal umbilical cord attachment, and the most universally recognized surface landmark of the entire abdomen.
We now zoom in on the single most surgically important surface anatomy point of the entire abdomen, McBurney's point. Named after American surgeon Charles McBurney, who described it in 1889, this point represents the most common surface projection of the base of the appendix, where it attaches to the cecum in the right lower abdominal quadrant. To locate McBurney's point, you need one anchor landmark first: the anterior superior iliac spine, abbreviated ASIS. The ASIS is the easily palpable anterior extremity of the iliac crest, the bony prominence you can feel on the front of your pelvis when you place your hands on your hips. In underweight individuals, the ASIS is often clearly visible as a bony protrusion. Once you locate the ASIS and the umbilicus, draw an imaginary line between them. McBurney's point is located exactly 1/3 of the distance from the ASIS toward the umbilicus. This point roughly corresponds to the most common location of the base of the appendix. Clinically, it is the primary site of maximal tenderness in appendicitis, a positive McBurney sign, and is the precise target for surgical incision during an open appendectomy. Every clinician must be able to locate this point instantly.
Descending from the abdomen into the pelvic region, we reach one of the most important surface boundaries in clinical anatomy, the inguinal crease. The inguinal crease is the visible skin fold that runs obliquely across the front of the hip, marking the structural transition zone between the anterior abdominal wall and the anterior thigh, between the trunk and the lower limb. It runs from the anterior superior iliac spine, the ASIS, as its origin, diagonally downward and medially to the pubic tubercle as its insertion point. Anatomically, this crease directly overlies the inguinal ligament, the fibrous band that forms the floor of the inguinal canal and the superior border of the femoral triangle. Below this crease, the femoral artery, femoral vein, and femoral nerve all exit the abdominal region and enter the thigh. This is why the inguinal crease is a critical access landmark for femoral artery catheterization, femoral nerve blocks, and groin hernia repair. Like the linea alba, the inguinal crease is distinguishable in most patients, but may be distended or obscured in obese individuals. Palpating the femoral pulse is performed by pressing into the midpoint of the inguinal crease, the midpoint between the ASIS and the pubic symphysis.
We now map the surface anatomy of the external genitalia, an essential component of clinical examination that all healthcare professionals must understand with anatomical precision and without ambiguity. This slide presents both male and female external genitalia from their standard examination perspectives. In the male external genitalia, from the anterior view, the primary visible structures are the penis and glans penis, the cylindrical shaft terminating in the rounded glans, and the scrotum, the regated cutaneous sac inferior to the penis housing the testes. The scrotum is examined by inspection for asymmetry and palpation for testicular masses, varicoceles, and hydroceles. In the female external genitalia, from the inferior view, the named surface structures are the mons pubis, the fatty tissue pad overlying the pubic symphysis that divides to form the labia majora, the glans clitoris, the visible surface protrusion of the primarily internal clitoral structure, the labia majora, the outer protective folds, the labia minora, the inner mucosal folds, the vulvar vestibule, the space between the labia minora containing the urethral and vaginal openings, and the perineum, the region posterior to the genitalia and anterior to the anus. All of these structures are examined during obstetric, gynecological, and urological assessments.
Crossing the inguinal crease, we enter the lower extremity, beginning with the anterior thigh. The surface form of the anterior thigh is dominated almost entirely by a single muscle group, the quadriceps femoris. This exceptionally large four-headed muscle dictates the primary surface shape of the entire anterior thigh. Its four heads, rectus femoris, vastus lateralis, vastus medialis, and vastus intermedius, create the characteristic muscular contour visible from the groin to the knee. At the distal end of the anterior thigh lies one of the most recognizable surface landmarks in the human body, the patella, or kneecap. The patella is a sesamoid bone, a bone embedded within the quadriceps tendon, and it covers the front of the knee joint. But here is a fascinating clinical caveat most students don't know. The patella follows a developmental timeline. In a newborn infant, the patella is entirely cartilaginous, no bone at all, and cannot be palpated as bone. As the child grows through early childhood, the cartilage progressively ossifies through multiple ossification centers. By adolescence and adulthood, it becomes a solid triangular bone, clearly visible as the bony prominence on the front of the knee, and easily palpable in virtually all adults, regardless of body habitus.
Just below the patella and the knee joint, the proximal lower leg presents three critically important bony surface landmarks that every clinician must be able to locate by palpation. The first is the tibial tuberosity, the anterior bony bump located immediately inferior to the patella on the front surface of the proximal tibia. It is the primary attachment point for the patellar tendon, which is the inferior continuation of the quadriceps femoris tendon after it passes over and encases the patella. The tibial tuberosity is highly palpable as a firm, prominent bump, especially in individuals with powerful muscular legs. Clinically, it is the site of Osgood-Schlatter disease in adolescent athletes, a painful apophysitis caused by repetitive traction stress on the developing tibial tuberosity during periods of rapid growth. The second landmark is the proximal head of the fibula, the irregular lateral bony bump at the outer side of the proximal lower leg, directed upward, forward, and medially. The common peroneal nerve wraps directly around the fibular neck, just distal to this head, making it extremely vulnerable to compression and injury at this precise surface point. The third landmark is the shin, the palpable long anterior shaft of the tibia running the full length of the lower leg, covered only by skin and periosteum.
We now rotate to the posterior surface of the thigh, the surface form of the back of the upper leg, which is defined by the hamstring muscle group. Three muscles create the posterior thigh form: the biceps femoris laterally, the semitendinosus medially with its long, round, cord-like tendon, and the semimembranosus, highlighted on this slide, which runs along the deep medial aspect of the posterior thigh with a distinct membranous tendon inserting on the posterior aspect of the medial tibial condyle. The semimembranosus is one of the three hamstring muscles that collectively define the posterior surface shape of the thigh. Its membranous tendon runs medially toward the tibia and is palpable as a flat, broad structure in the medial popliteal region. There is an important visibility factor that applies to all posterior thigh surface anatomy. Diagnostic surface visibility of these muscles is highly dependent on the patient's body fat percentage. In lean, muscular athletes, the individual hamstring muscle bellies and tendons are clearly visible and palpable. In overweight or obese individuals, the surface definition may be completely lost, making differentiation of individual muscles by palpation quite challenging. This is a clinical reality that every examiner must account for.
The back of the knee is occupied by one of the most important anatomical spaces in the lower extremity for clinical examination, the popliteal fossa. As a surface anatomy landmark, the popliteal fossa presents as a shallow, diamond-shaped depression on the posterior aspect of the knee joint, most visible when the knee is slightly flexed. This depression is the surface projection of the fat-filled space that lies deep to the skin and fascia. Beneath that skin surface, in the deeper anatomical layer, lies an extraordinarily rich collection of neurovascular structures that make the popliteal fossa a prime clinical target. The popliteal artery is the deepest structure within the fossa and is the location for palpating the popliteal pulse, one of the key peripheral pulses assessed during vascular examination. The popliteal vein and the small saphenous vein, which terminates here by draining into the popliteal vein, complete the venous component. The tibial nerve and common peroneal nerve both travel through this space. The sciatic nerve divides into these two branches at or just above the fossa. And the popliteal lymph nodes filter lymph from the leg and foot. Clinically, the popliteal fossa is also the site of a Baker cyst, a posterior knee swelling from excess synovial fluid that is palpable in this space.
The posterior lower leg presents the most powerful and most clinically significant surface anatomy of the entire lower extremity, the calf bulge and the calcaneal tendon. The calf bulge is the prominent muscular mass on the back of the lower leg, formed collectively by the triceps surae muscle group, consisting of the larger, two-headed gastrocnemius muscle sitting superficially and the broader, flatter soleus muscle lying deep to it. The gastrocnemius creates the visible dual-headed contour of the upper calf, while the soleus provides the wider lower calf shape. Together, they are the primary plantar flexors of the ankle.
They push you up onto your toes and drive you forward with every walking and running step. These muscles converge inferiorly into the calcaneal tendon, universally known as the Achilles tendon. This is the common tendon of the triceps surae and plantaris muscles, and it is the thickest, strongest tendon in the entire human body. It inserts directly into the posterior surface of the calcaneus, the heel bone. The Achilles tendon is universally palpable as a thick, cord-like structure running vertically down the back of the ankle. Clinically, it is the site of Achilles tendinopathy and complete rupture, which produces the classic positive Thompson test.
The ankle presents two of the most clinically important bony surface landmarks in the lower extremity, the medial and lateral malleoli. These are the prominent bony bumps you can see and feel on the inner and outer sides of every ankle, and they are among the most frequently examined landmarks in emergency medicine following ankle injuries. The comparison matrix on this slide highlights the key differences between them. The medial malleolus originates from the distal end of the tibia, the shin bone, and projects as the bony prominence on the inner side of the ankle. Its common name is the inner ankle. Relative to the lateral malleolus, the medial malleolus sits at a higher elevation. The lateral malleolus originates from the lower end of the fibula, the outer leg bone, and forms the bony prominence on the outer side of the ankle. Its common name is the outer ankle. The lateral malleolus sits at a lower elevation than the medial malleolus, a difference of approximately 1 centimeter. This difference in height is clinically critical. The lower lateral malleolus provides less bony stabilization to the lateral ankle, which is why lateral ankle sprains, injuries to the lateral ligaments, are 4 to 5 times more common than medial ankle sprains. The Ottawa ankle rules use tenderness over both malleoli to determine whether ankle x-rays are needed after trauma.
We arrive at the terminal surface anatomy of the lower extremity, the foot. The foot is mapped across two major surfaces, the dorsum above and the plantar sole below, and it contains two critically important clinical surface landmarks. The first is the calcaneus, the heel bone, which serves as the posterior anchor of the entire foot. The calcaneus is the largest of the 7 tarsal bones and protrudes posteriorly to anchor the calcaneal tendon. It is readily palpable as the hard, bony posterior projection of the foot, and it absorbs the initial impact force during heel strike walking, up to 3 times body weight. Calcaneal fractures are the most common tarsal bone fractures, typically caused by a fall from height landing on the feet. The second is the dorsum of the foot, the superior surface, which contains the extensor digitorum brevis and extensor hallucis brevis muscles lying flat against the dorsal tarsal and metatarsal bones. On the dorsum lies one of the most clinically vital pulse points in the entire body, the dorsalis pedis artery. This artery, a continuation of the anterior tibial artery, runs along the dorsum of the foot between the first and second metatarsals and is readily palpable as the pedal pulse, used in vascular assessment to confirm peripheral arterial circulation to the foot.
Now we synthesize the surface musculature of the entire lower extremity into a clean anterior versus posterior contrast, because understanding these two mechanical systems as unified functional drives is the key to understanding how the leg produces movement and how injury to each system produces predictable clinical deficits. The anterior system of the lower extremity is dominated by the massive quadriceps femoris, the four-headed extensor mechanism of the knee. The quadriceps pulls through the patella via the quadriceps tendon, which continues as the patellar tendon, anchoring to the tibial tuberosity on the front of the proximal tibia. This anterior system is the engine of knee extension, standing up, kicking, climbing stairs, and decelerating during running. The posterior system is a dual-zone architecture. The upper zone, the posterior thigh, is defined by the hamstrings, biceps femoris, semitendinosus, and semimembranosus. They control hip extension and knee flexion. The lower zone, the posterior calf, is defined by the triceps surae, gastrocnemius and soleus, anchoring to the calcaneus via the Achilles tendon and driving plantar flexion. Anterior tears, quadriceps strains, and patellar injuries are extension mechanism failures.
Posterior hamstring tears and Achilles ruptures are flexion propulsion mechanism failures. Two systems, opposite functions, complete lower limb locomotion.
We close with the complete clinical application synthesis, pulling together every surface landmark we have studied into the 5 examination modalities that define clinical practice. Palpation targets 3 key landmarks from this video: the ASIS for McBurney's point calculation in appendicitis assessment, the tibial tuberosity for quadriceps mechanism assessment, and the malleoli for ankle fracture evaluation using the Ottawa ankle rules. Inspection anchors to 4 surface features: the linea alba for midline assessment and diastasis recti, the inguinal crease, noting any distension in obese patients, the external genitalia for urological and gynecological examination, and patella effusion status for pediatric knee assessment. Auscultation targets 2 pulse points: the popliteal artery, accessed through the popliteal fossa for lower limb vascular assessment, and the dorsalis pedis artery on the dorsum of the foot for peripheral circulation assessment. Percussion is used to assess underlying abdominal organ density across topographically mapped abdominal regions. Function testing assesses 2 biomechanical systems: the calcaneal tendon for weight-bearing and plantar flexion integrity through the Thompson test, and quadriceps mechanics through knee extension testing. The synthesis message is simple and profound. Surface anatomy transforms the hidden body into an accessible diagnostic map. Subscribe to Med Studious for the full clinical anatomy series.